Guys, after subscribing to this channel, please make sure that you also press the bell icon so that no notification, no new video of mine, any educational video, is missed by anybody.
We'll be discussing majorly 3-4 conditions tonight. Hypothyroidism, okay, hyperthyroidism, and postpartum thyroiditis mostly. So we talk about hypothyroidism, that's going to go on for some time. How should women with hypothyroidism and subclinical hypothyroidism be cared before the pregnancy? So pre-pregnancy in women with overt, I know that I'm hypothyroidic. I've been taking supplementation. So I'm the ones who are having severe subclinical hypothyroidism. That means I got her tested for whatever reasons, maybe for infertility or whatever. I got a test and her thyroid comes out to be more than 10. TSH is more than 10 milliunits per liter. Milli international units per liter. In exam, sometimes they ask what's the unit. And people fumble there as well, okay? So TSH more than 10 million international units per liter, accompanied by normal FT4. Titration of the levothyroxine to achieve a preconception TSH less than 2.5. Nowadays, 2.5 is considered a good cutoff. TSH less than 4 should also be ideal, but actually it's good, but ideal is 2.5. So you have to, kind of titrate your levothyroxine dose in such a way that your TSH is coming less than 2.5. Okay. Pre-pregnancy in women with subclinical hypothyroidism, particularly those already known to be TPO antibody positive, treatment with levothyroxine should be considered starting preconception with titration to achieve a preconception TSH less than. Now, this was a confusion from a really long time. See, there are people with subclinical hypothyroidism. Okay. Please mute yourself, guys. Who is it? All right. Subclinical hypothyroidism, that means the TSH is between upper limit of non-pregnant range and 10. That means I'm talking about 4 and 10. Accompanied by normal T4. And if they have TPO antibodies, treatment with levothyroxine should be considered, and that should be started preconception. And here the idea is to get the TSH level less than 2.5. Are you with me or not, guys? Are you understanding what I'm saying? Come on, tell me. If the TSH level, okay, answer this question. If the TSH level is 3.5 and anti-TPO antibodies are positive, will you give levothyroxine or not? Answer me this question. I have made this question for you to, understand whether you're getting the concept or not. Yeah. Everyone, I want to know how many of you have understood this thing, what I'm asking you of. Okay, Dipali says yes. What about others? I'm again repeating the question. Suppose you are having a TSH of 3.5 and the anti-TPO antibodies are positive. Will you treat this patient with levothyroxine or not? Is the question. Okay, Revati says yes. Dipali says yes. Others are sleeping. Where are the others? Let me hear whosoever is there. Meghna, what about you? Devi Priya, Anita, where are you? Isha, Arsh, Lata, and Revati. Revati is already answered. Hema. Come on, guys. What do you think? What is your answer? Should this be? Yeah. Yes. TPO antibody positive and TSH more than 2.5. She should be given levothyroxine. Great. Okay, what do you say? What do you say if it is not? Let's say that TSH is 3.5 and there is anti-TPO is absent. Now what? Then what? Anti-TPO is not positive and it's 3.5. What do you want to do with these women? One is saying no. Revati is saying no. Dipali is saying no. What about the others? See, you should always have an opinion. Always have an opinion. Okay. You will get the answer and you will get the guideline answer in a short while. Okay. see, this is why I was saying all this till, where exactly we are going and how much is actually coming up. So let the guidelines speak for themselves. I'll be answering this in a short while. Yes, you have a no correct answer. We should see it as a total. The free thyroxine level should also be checked. That's true, but still. Now, women with isolated low T4. That means TSH is fine. I'm talking about subclinical hypothyroidism. But isolated FT4, TSH is still compensating. Diagnosed outside of pregnancy should be referred to the endocrinology team. Correct? That's different. But I'm talking about now the people who are planning to conceive or who are already pregnant. Now, women who are on levothyroxine therapy for hypothyroidism should be counseled to self-initiate an empirical increase in their dose of levothyroxine by approximately 25 to 30%. As soon as they have a positive pregnancy test. Reason. Come on, guys. Tell me the reason for this. I said something and I need to know why. Question is that people who are now pregnant, okay, and they're asked to upscale their levothyroxine dose. Positive pregnancy test, yes. The moment their pregnancy test is positive, they should upscale a little, 25 to 30%. They should increase the levothyroxine dose. The question is why. Very good. Dipali is on fire. Great. What did we say, guys? What happens over here? Usually what happens in the first trimester. And by the way, very important, for the brain development of the child, for all the cognitive functions to develop, what do you require? You require maximum, scrutiny of thyroxine and thyroid hormones in the first trimester. So if you're failing here, there's nothing that you will achieve after 20 weeks. You maximum require to titrate your levothyroxine dose in the first trimester, because here is where two things are happening at the same time. First of all, you have a transient thyroid dysfunction. That means what? What? I'll tell you. It's coming up. Meghna. So, see, I was in the flow. So yeah, I was telling you that what happens in the first trimester, two things. First of all, the baby's brain is developing and you require thyroxine at that. And you cannot afford to have hypothyroidism. But at the same time, what you're having over here is suddenly this thyroxine hormone, there is a transient, change in the level of the thyroid hormone, as a result of which you have to increase it a little to compensate for the initial part of the first trimester because of the hemodilution of the blood and the excessive hemodynamic changes going on in the body, as a result of which there is hypermetabolism, and then you might require, so there is a transient dip. Okay, so you upscale the levothyroxine by 25 to 30%. How do you do that? I'm just trying to tell you. Doubling the dose of levothyroxine on 2 days of each week, you can do that. For example, you're taking, let's say 50 microgram. So let's say you're taking 50 microgram for the whole month, and maybe on Tuesday and Friday, I decide that, okay, for Tuesday and Friday, I'll take, instead of 50, I'll take 100. So only on those 2 days. Something like that. That you can do yourself for the first trimester. That's what they're saying. And I'll just mark this because this is kind of important. And when you revise this, you will remember what exactly I meant by that.